and Dr. Kaushal Malhan. The panelists for this session would be Dr. Nitin Modi, Dr. Gautam Tawari, Dr. Kumar Dussa, and myself. Dr. Desai, you can take over, please.
Thank you very much, WIROC organizers. Thank you, panelists, for agreeing to be on the panel. Chairman, sir, with your permission, may I? So, I have a collection of about 6-7 cases. The thrust is on complications that you often see in shoulder practice. And I urge all my expert panelists to make the answer short and crisp. So in the given allotted time, we can show more and more cases. So case 1. Here is a 65-year-old gentleman who had a model aircraft injury. And these are his x-rays. So let's start with Nikhil. Nikhil, what do you do for this? What would you do?
So it looked like a 4-part fracture with a dislocation of the head. 65-year-old male, if he's an active, physiologically active patient.
Active.
Yeah, then I would always offer an osteogenesis for him in the form of open reduction and plating.
Plating. Kumar?
CT and plan for osteosynthesis.
Can you be more specific? Like I would like an answer, plating, full stop.
Yeah, full stop. Plating,
Okay.
done.
Nitin?
I'll do a reverse for him.
Straight reverse? 65? No osteosynthesis for you? He's an active guy.
I think reverse is more predictable in my hands rather than osteosynthesis. It's a fracture dislocation, high chance of AV in here.
Okay.
I think I'll agree with Nitin. I'll go for a reverse.
Reverse. So, an orthopedic surgeon who he went to did a plating. He reduced the humeral head. He plated. Quick answers again, starting with Nikhil. Acceptable, good?
Yes.
Anything you're worried about, or this is okay?
No, worried in the sense I'll keep a serial X-ray just to see the vascular.
No, as you see now.
Fixation, I'm sure they have done suture repairs with the good reduction. Yeah. I'm quite happy with it.
Okay. Everybody agrees with him, or any dispute? Remaining 3 panelists?
I think I'm just a bit concerned about the tuberosity over there.
So am I.
Whether they have repaired it or not, and we'll have to keep a close eye on this.
So, Gautam is worried about, Nitin is worried about the tuberosity. Gautam?
The greater tuberosity is not in place. So I think...
So 2 panelists are worried about the tuberosity. This
tuberosity is not in place.
This patient now presents to me 5 months post-op with severe pain and stiffness. That is when I come into the picture. Now, quickly again, let's start with Gautam. Gautam, short answer. Kya lagta hai? Theek hai sab? Severe pain and stiffness.
So stiffness is because the head has completely valgized and the greater tuberosity is behind, so the cuff's not functioning. I'd say it's doomed to fail.
Okay. Nitin?
I won't accept that.
You mean you agree with him, nothing to add?
Absolutely.
Okay. Both of you feel it's the GT and head is valgus. I mean, it's in valgus, but yeah. Okay. Kumar?
Yeah, it's in valgus, so nothing more to add to what they told.
Okay.
I don't think we can comment on valgus on this. This is an internal rotation view. So, I mean, actually it's a lateral view. I think it's probably he was protected too long and that's why there's stiffness. I would want to get a better image.
Okay. So, I did a CT scan afterwards and this is what it was. Now what do you do? Okay, let's start with Nikhil, quickly. Kya karoge ab? 5 months post-op, the glenoid fracture was missed.
Yeah. A rehab first to see if he is relieved.
He's in severe pain and stiffness. I can't move my arm, doctor.
Probably fix the glenoid fracture.
Open and fix the
Open and
glenoid.
fix.
And what prognosis will you give to the patient? ठीक हो जाएगा सब?
Guarded. Guarded.
Guarded prognosis. So you want to fix the glenoid piece. Kumar?
I did say CT as the first instance.
I heard that. I
You
noted
have a
that.
case at Desai.
Very good. Yes.
So definitely need to fix the glenoid, but with 65, not a very good scenario.
Okay, Nitin?
I'll fix the glenoid, but very, very poor prognosis for him. Very, very.
Gautam?
I'll mobilize him, see where he goes. If he continues to be dislocated, I'll reverse him.
You'll do a
Reverse shoulder.
reverse shoulder. So the patient had a reverse shoulder replacement. He got fed up of the Indian doctors, went overseas and got a reverse shoulder replacement done. Take home message, whenever you deal with proximal humerus fractures, please, 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 a CT is mandatory. Case scenario 2. 90-year-old, a Bollywood superstar's grandfather, just to make you a little nervous. Now, starting with Gautam, what did he do? I offered conservative treatment to them initially. They went home with conservative treatment, called me up after 4-5 days. Doctor, we can't see him like this. Please do something. So take it from there.
So the head is in varus. I would fix this. I would fix this with either a plate or nails, whatever is the fix.
that's
I would
not-
fix with plate.
I want an answer, nail plate, full stop.
Plate.
Plate, okay. Nitin,
Nail for me.
nail.
Nail. Nail,
Plate.
nail.
Kumar, did you say what?
I did say nail.
Nail. Okay, 2 nails and
Plate.
plate. So I did a plating, and if you can see there with some bone grafting, quickly, is it acceptable? Your registrar sends you the picture post-op, you already left the OT, and he says, sir, this is the X-ray. What would you say? Okay, pack up and send him to the floor, or would you be worried? Is it okay? Satisfactory? Remember, मैंने किया है.
Should I start?
It's fine. Okay, Kumar, anything critical about this fixation? You're happy? Good fixation?
Yeah, I'm quite happy.
Happy, okay.
I'm happy except the drain.
Except the drain. Okay, yeah.
I'm happy. I would probably like screws a little shorter.
Which screws? The one in the head?
Once in the head. Yeah,
Okay.
probably.
So he comes to me after about 3 weeks with this X-ray. Now take it from there. Let's start with Gautam. क्या करोगे?
So this is biology. So I think the plate needs to come out and needs to be refixed. So you get a CT, find out what's going on. I'm not sure what is the best way here out. Probably end up doing a reverse, but we'll see.
Reverse, okay.
One solution for him, reverse shoulder.
Reverse, okay.
Yeah, reverse for him. There's no other
Reverse.
solution.
Reverse
Nikhil?
shoulder. Reverse shoulder.
Reverse shoulder. So he had a reverse shoulder replacement. He lived about 4 years after that, did very well and passed away for other reasons. Take home message. Think twice. I repeat, think twice before you offer plating osteosynthesis for proximal humerus fractures, particularly 4-part in elderly age group. Case 3. This patient comes to me from somewhere north of India. Sorry about the poor quality of X-rays, but that's what she had with her. She's 56. Somebody had done a plating and looks about to fall apart, as you can see. What will you do, starting with Nikhil?
56.
56, dominant side.
Probably do a reverse shoulder.
56, reverse. Okay?
No.
Are you worried, Nikhil, that age is too young?
I mean, there's hardly any proximal fragment left. I don't know whether osteosynthesis really will work for this.
Okay. Kumar,
Osteosynthesis will not help here. It's already gone.
what will you do?
Reverse.
Reverse, 56, okay.
CT, rule out infection, and I'll do a reverse.
So 56 is too young for me to do a reverse. I'll get the metalwork out. Second thing is the plate's too long. So you're looking at a very long stem if you're doing a reverse. I'll probably see if the patient is good enough for a hemi and then counsel them for a future reverse when the glenoid wears off.
Are you comfortable with the prognosis of hemis?
I mean, she's pretty bad here anyways. This shoulder's not moving. You have worries of infection. Even if you put a reverse at 56, she's probably going to last. You will have to revise that reverse. So
Nobody would consider out of the 4 panelists fibula graft with revision, fixation, plating.
I don't think there's any head left for you to heal. So
Okay. The surgeon who was looking after her in North India went ahead and did a hemi. And as you can see, the hemi is loose. There is a fracture at the tip. And this patient who had a fracture in 2009 now presents to me in 2012. That attending surgeon removed the hemi, put beads, antibiotic beads, and this is what she comes to me. This is where I come in the picture. So now,
So I don't think you've got a lot of choice. It's infected. You have to make sure that the infection's gone and then probably consider a tumor prosthesis.
tumor prosthesis, okay?
Would agree. Control the infection first. Once it's cleared off, proximal humerus replacement for her.
Proximal humerus replacement.
What is the condition of the limb now? I mean, the shoulder now?
Limb is otherwise fine, elbow is good, hand function is good, but the shoulder is flail, of course.
Flail.
Infection is under control now.
Okay. So a tumor prosthesis. If
Nikhil?
I might consider leaving her alone also if she's not in too much pain.
She says no, she wants something, the arm is useless, it's a dominant arm. So we did a reverse shoulder replacement. We didn't do a tumor replacement prosthesis. I bone grafted the segmental fracture area, and she is now, I think, 6 years post-op doing reasonably well. Take home message, again, proximal humerus fractures, 4-part plating in elderly, be careful, think twice. Case 4. So comminuted 40-part fracture in a 56-year-old male. Nikhil, what will you do?
CT scan.
CT scan shows comminuted 4-part fracture, smashed up, 56.
Probably do a trauma hemi. A hemi.
Hemiarthroplasty. So what I'm going to do is, I've done some surgery which I'll show you, and he has an excellent result. Look at that function. Excellent forward elevation, external rotation, and internal rotation did very well with a hemi. And the tuberosities have united, as you can see. Now, the reason I am skipping this, what I did, I want the panelists to tell us, do you think hemiarthroplasty for 4-part fractures is a good operation?
Provided the tuberosities are meticulously repaired.
So how is that, how often is that, and how confident you are of having problems or smooth sailing? So is it a good operation? Would you recommend?
I would.
You will, okay. Kumar?
Yeah, definitely. Because
Hemi is a good operation.
it's a good thing for a 56-year-old.
Yes,
Fairly-
it is in the hemiable age group I'm talking about, not in 40s.
Yes, yes.
You think you are confident that you can give a predictable outcome?
Yeah, if you are confident on table that the tuberosities has been well placed at good position.
Okay.
I think a lot depends on the healing of the tuberosity, relying on the tuberosities here. In my hand, I will do a reverse. Age you should consider that, but I think function is more important.
I'm talking about between 50 and 70. Let's do that.
Reverse.
50 and 70, 4-part. So you think hemi is something you would be happy to do? Nitin?
If he's 50-year-old, I would consider hemi, but if he's 70-year-old, I'll go for a reverse.
Between 50 and 70. Take out reverse from the scenario.
Me.
Hemi, okay. Gautam?
So the literature does not support hemi that much. If you see across, the outcomes of hemi versus outcomes of 4-part fixations are largely the same because both of them don't give you a lot of movement. You get the odd results where you get good movements. However, that is very surgeon dependent. So people who do a lot of hemis and get good results should be doing a lot of hemis. But in the UK, we would not do a lot of hemis. You would either fix or reverse. That is the standard of care we offer. So I would, in my hands, that patient, yes, hemi, but with counseling that you might need another one in future if you don't get a good result or if you're not happy.
So beware, just like plating, I warned you, same is the story with hemiarthroplasty for 4-part fractures or fracture dislocation. Why do I say that? I keep getting this one case almost every 15 days or a month. This is example 1, a cuff deficient hemi, which is worse than conservative treatment. The results are terrible. You would have rather left it as it is. Case number 2, cuff deficient hemi. The humeral head is escaping superiorly. They are very painful with very, very poor function. It's a disaster. Case 3. Case 4. So, is this hemi a problem only with us? No. Hemis are very unpredictable. The reason is because it is very, very difficult to get the tuberosities to heal consistently, and it's very hard to tell the patient, yes, sab theek ho jayega. And this problem is worldwide. So let me summarize tuberosity problem. Almost 50% of the hemis will have a problem with tuberosity union, and if the tuberosity doesn't unite, you have a cuff deficient hemi. This is a multi-center study from France. We all know Pascal Bellew is probably one of the best shoulder surgeons in the world, and even in his hands. So forgive me, one of the panelists, even if you are doing hemis day in and day out, hemis to get a predictable result is very, very difficult. And therefore, the take-home message is, when you do a hemi, be careful. Do not undertake hemi unless you are sure that you have the experience, the expertise to get the tuberosities to unite, and keep in mind that even the best of surgeons have a tough time getting the tuberosities to unite. Case number 5. So here is a general surgeon by occupation. He had what looks like, this is the only X-ray he had. It looks like 3 or 4 part fracture, and somebody did a hemiarthroplasty on him, and the hemiarthroplasty, of course, was a disaster. The tuberosities, as expected, did not unite. He is in pain and very poor function. So he went to a shoulder surgeon who revised the hemi into a reverse shoulder arthroplasty. Once again, the same story. And this is in the recovery. In the operation theater recovery, they did a post-op X-ray. You can see the staples there, and the head is, the reverse has dislocated. Okay, now, starting with Gautam. Ab kya karna hai? Recovery mein hai.
So, first thing is reduce this, check the neurovascular status. You want to get a CT of this, find out whether the components have been put in the right orientation. If the components are not put in the right orientation, you've got a problem.
So reduce it, send him home, then aram se do a
reduce it. Nahin, kuch aram se kuch. Reduce him, get a CT, tell him that it's not in place. It would probably need a revision. Within this, if the components are in orientation, then you can consider sending him, but otherwise no.
The component mainly, as you can see, it must be the humeral component, if at all.
But what rotation is put in? We do not know what's his native rotation. So there are few things that need answering before we go ahead and say, okay, I'll operate this and this is what I'll do.
Okay, the components are in good position now.
So what is his native rotation on the other side? So if it's dislocated, the balance is not there.
Okay.
Sending him back with a poorly balanced reverse
therefore
is problem.
So therefore, what will you do?
So you have to go in and balance it.
And do what?
So balancing could be because of the way it's been put in. So it looks like it's a 135 degree humeral tray. You could go 150, you could go
So you are suggesting revise the humeral component?
I don't know the problem. So yes, but it needs revision is what I can tell you.
Okay. Nitin?
So CT, urgent CT, and then
CT shows component are in good alignment.
It's an unstable shoulder, so I will revise it. I won't let this patient go home like this.
Revise and do what?
So first of all, as he said, I agree with him that you need to find the orientation of the component.
I said CT done, components are in good position. Now?
We have somehow to stabilize the shoulder.
Yes.
Either use a thicker poly or change the proximal component of the humerus.
Change the poly to a thicker poly.
Or a more constrained one. We have a lipped one as well with the lima.
Okay. So the surgeon reduced it and in the OT itself send the patient home, and the patient comes back with this dislocated reverse again. Now Kumar, he's come to you.
Are we missing any neurological component?
No neurological component. Everything is fine. Deltoid is firing. Okay.
No, it's a big problem.
Problem. Okay. Nikhil?
Has he just reduced it or changed the poly also?
He reduced it.
So probably it requires a change in the poly. The reduction was not enough. The primary problem was not addressed.
Sorry, what he had done is he when it reduced and dislocated, he changed the poly to a thicker poly, as is seen on the slide. That is surgery number 3. Hemi was surgery 1, reverse was surgery 2, change of poly to a thicker poly was surgery 3, and after putting a thicker poly, he has dislocated. He's already undergone 3 surgeries. He is a general surgeon by occupation. Okay. Anybody else wants to throw any light? Ab kya karna hai?
So, can I ask what is the component sizes? So, the humeral head, the humeral tray, and the glenosphere, they don't look very matched to me.
They are. This is
both same sizes. So they've put a 40-40 or whatever they've done.
French evaluate is large size glenosphere.
And a matching humeral tray.
Of course, yes. So, when it comes to me, I do the surgery number 4. What I did was, there is a huge myositis mass, if you see, on the medial side. I excised the whole myositis mass, which was impinging and pushing the head out. I excised the myositis mass. Fortunately, the large size of the component has a retainer poly. So I put an augment on the humeral side. I did not have to revise the stem. Just remove the tray, put an 10 mm augment, balanced it, excised the myositis mass and put a retainer poly. That was surgery number 4. So now take home message from the last 2 or 3 cases. I repeat, be careful when you undertake hemiarthroplasty for fractures of proximal humerus. Not an easy operation, difficult to get consistently good result. And whoever decides to handle proximal humerus fractures in your practice must know about reverse shoulder arthroplasty. I personally feel you should not undertake fractures of the proximal humerus unless you are familiar with reverse shoulder arthroplasty.
So
Case 6.
If I may ask,
Yes,
what did you find as the reason for the dislocation in the first instance?
Balancing. And if you look at literature, the commonest complication of reverse for fractures is instability post-surgery. That is in the literature worldwide. That's the commonest complication.
So if I may ask you, what are your tailor-made indications for a hemi shoulder?
I wouldn't do it.
So you stopped doing hemi.
Today at 4:25, I have a talk on what will I do. Between 50 and 70 is when the hemis are recommended. Above 70, there is a consensus worldwide. If you have a fracture which needs surgery, above 70, do a reverse as a primary modality. Below 50, jo marji aap karo, whatever you are comfortable, nailing, plating, whatever you like. Issue is 50 to 70. And unfortunately, all these fractures are commonest between 50 and 70. What will I do? 4:25 today evening.
They're having the Profar 2 trial now, above 65, hemi versus reverse.
Yeah.
I think we know the results are going to be better with reverse anyways.
So now this is a 21-year-old male, post-traumatic, 3 dislocations in 2 years. Somebody did an arthroscopic Bankart repair in 2010. And after the surgery, it dislocated twice. In 2011 with trivial injury. And I did a CT scan. The patient came to me after the failure of the first operation. And what do you think? Why it failed quickly? It's not a very challenging case. Nikhil, why it failed, you think?
Surgical, maybe the technique, I don't know. Because it's a small bony Bankarts.
Yes. Do you think it is reduced well?
No, it's not reduced well.
So you think it's a technical error?
Yeah.
Anybody else differs on that? Or thinks of some other reason? Like, that doesn't look like there is any significant bone loss on the glenoid side, does it? So, you all agree with Nikhil, or you want to add something as a possible cause of failure of the first operation?
A remplissage also would have been.
Remplissage wasn't done. It's a small Hill Sachs, if you see. Any other reason? Remaining 3 panelists? So no other reason they think it. You all agree that it's a poorly done bony Bankart repair. Nod your head, say yes or no. Or you want to add something? Remaining 3 panelists?
So, the morphology of the glenoid, I'm not sure if it is a kind of a slightly odd in morphology, but if it is same on both sides,
It's same. There's
So-
nothing wrong with the morphology
I think it is not great fixation of the bank cut.
of the bony bank cut. Nitin, you think?
I
You
agree.
agree? Yes?
Yeah, yes.
So, I did a revision arthroscopic bony bank cut repair. Now it is more than 5 years post-op, doing very well. This is not the case I wanted to show you. What I want to ask you is this. Now, I want you to answer in form of 6B, 6C, 6D, 6E. What will you do quickly, starting with Nikhil? Nikhil, 6B, 6C, D, E. क्या करोगे आप? 6B,
Oh, open fixation.
open fixation, 6B. 6C,
So 6B is a bony, I'll do an arthroscopic bony bank.
why don't you answer like this? 6B arthroscopic bank
Bony
cut.
bank.
6C,
6C also I would attempt an arthroscopic repair. Since
you are
it's
confident you'll be able to manage that?
else I'll convert on table to doing an
So
open.
you will consent the patient that I
Yes.
do arthroscopic, kuch problem ho to I'll shift to open.
Yes.
You think open is going to be easy?
For me, if I can get 2 sutures at the apex and bring the fragment back, I should.
Will not put any metal in the fragment.
No, I'll do a suture bridge.
So first arthroscopic, second arthroscopic, SOS open, 6D,
Open fixation
open fixation. Fixation technique,
with screws.
cannulated screws.
6E.
Okay, 6E,
6E. Can do an arthroscopic.
arthroscopic, large fragment, you can manage it mostly. Okay, Kumar, you, 6.
Yeah, same.
E,
B
take
and
off.
E can be done arthroscopically.
No, not can be. What will you do?
Will do arthroscopically. And C and D has to be opened.
You mean D and E?
Sorry, C and D, no? Yeah. Yeah, D open, annulated screws. C also open.
So, B and C arthroscopic, D and E open. Nitin,
6B arthroscopic, 6C arthroscopy stroke open, D open, E possibly arthroscopy.
so only D open for you.
6C arthroscopy stroke open,
But D pakka open.
E pakka open.
Okay? Gautam, your baby.
So I think arthroscopic for B, arthroscopic for C plus minus open, D arthroscopic if is reducible, if not open. So D also scopy plus minus open. E, I think I can manage that arthroscopic.
Okay. So I did B, C, D arthroscopically, but E I conserved. He was a heavyweight WHO lady, somewhere from Europe. I conserved it, and this is the post-op 4 months follow-up CT scan. So I want to remind not only the audience but the panelists, do not forget that conservative treatment also works in many cases. She's done very well, it's healed beautifully. You can have a look at this. Lovely, you couldn't have done a better job what nature has done. Case scenario 7. All the 4 panelists are familiar with IG Toys and Guillermo's work, that if the glenoid bone loss, for benefit of the audience who are not into too much into shoulders, current trend is if the glenoid bone loss is more than 25% and the Hill Sachs is big enough to go off track, then you do lethargy plus remplissage. Correct? The last line.
Yes.
Number 4.
Yeah.
You all follow this dictum?
Yes.
You do. Okay. Kumar, do you follow this?
Yes, yes.
You do. So if the Hill Sachs lesion is off track and you do have a glenoid bone loss which is large, you would do lethargy with remplissage. This is what the recommendation is.
Yes.
You would, Kumar?
Yeah.
How many have you done, if I may ask? Lethargy with remplissage, and how do you do it? Because one surgery is posterior. Okay, while he thinks, I'll give you a chance again. Nitin, do you follow this protocol?
I mean, I hardly do remplissage. I just will do a lethargy on this one.
You wouldn't do a remplissage. So you disagree with this IG toy and
It's technically very difficult for me to do because, as you said, one is posterior, one is anterior.
do you agree with the idea of doing so much surgery on that small little
No.
shoulder joint? No, you don't agree. Okay, Gautam, you?
So I don't strictly follow this, but I have done latter J with Romplazage. I've done that.
And tell us, how did you do the latter J arthroscopic open?
So I do latter J's open because it takes me less time to do open than arthroscopic. But I scope all my latter J's, irrespective. So all of them are scoped. The fact that you have a large hill sacks essentially means it's off track or on track, whatever you want to call it. That's why I don't follow this dictum. I do arthroscopic Romplazage, come back, do an open latter J. Done. Takes me less time.
Okay. So this patient had at type 4, number 4, glenoid bone loss with an off-track hill sacks lesion. So by the books, the attending surgeon did a latter J with a remplissage. Patient comes to me 10 months post-op. Says, doctor, I have severe pain. I have done everything. I have done physio. My surgeon said he gave me an injection also. He went in and removed one screw also from the latter J site. But I'm in so much pain. Please chop my arm off. If you may, please. What do I do now? 10 months post-surgery. The second surgery that attending surgeon did was removing that one screw from the, or 2 screws from the latter J graft. Okay, now, let's start with Nitin. Nitin, ab kya karoge? 10 months post-op, 32.
First thing is to rule out infection here.
No infection.
Infection.
Nerve. Dr. Mukhi said, check for the nerve. Nerves are fine. EMG nerve conduction, okay, but severe pain. And even if it is nerve, what do you do? Which nerve?
Is it rest pain or pain in certain
pain on movement. He says, I do anything and the function is very restricted. Forward elevation about 20 degrees, internal rotation up to trochanter, external rotation 0, severe pain, crying. He's saying, you chop my arm off. I'll give you signed consent. Any ideas?
So, the latter J is not great. The glenoid
Stop. Why do you say that? Why is it criticize the latter J? It's not done by me, so feel free.
So it is not doing the job of increasing the glenoid face.
Is it supposed to do that job really?
Well, part of it is that, and part of it is obviously if they have good soft tissue attached on it. So if you have the pec minor and the coracobrachialis attached well, then you get the muscular stability because you go split the subscap. Obviously, my latter J's are congruent arcs, so they're completely different from this. But the only way I can see out of this is doing an iliac crest bone graft and repeating the latter J properly.
Stop. So are you indicating that the cause of his pain and stiffness is instability?
It looks like, or the other option is...
That you want to do another stabilization procedure?
No, but then, see, I've not seen the patient, so it's very difficult for me to judge.
I can tell you everything about the patient.
So the only two reasons why they are in pain is A, instability, and B, if it is adhesive capsulitis. So if they have adhesive capsulitis, you treat adhesive capsulitis.
Is there any cartilage wear at all?
He is totally stiff, which is opposite of instability. Correct me if I'm wrong.
Yes.
So would you want to do a stabilization procedure on such a patient who is stiff and in pain and crying?
So
are you worried that you might add insult to injury?
So the problem is he's stiff and in pain. The solution is really why is in pain, and the imaging is not enough to tell me that why this is in pain. So on the scan, I can criticize the scan, but that is only one part of the problem.
Okay. Nitin, your baby, what will you do?
He has two issues. One is pain and stiffness. I would like to know the status of the articular cartilage here. What's the articular cartilage due to trauma? Is it developing any early arthritis?
You can see that CT cut, and he has mild degenerative changes, which we see so often in so many 50-year-old, but they are not in agony, they are not in tears that chop my arm off.
I think his main concern is stiffness. I will probably scope him and see to assess the cartilage itself. Because on CT, as you say, it looks okay here, but he may have degeneration, we all know that.
I didn't do a scopy, but let's say I put a scope in and it shows a diffuse grade 2 osteoarthritis, 1 or 2 small patches of grade 3. अब क्या करोगे?
I mean, at his age, not a lot we can do. I think we have to manage him symptomatically. If stiffness is the main issue, I would do an hydrodilatation for him, an ultrasound-guided hydrodilatation, to see if that improves his pain and stiffness.
Kumar, you want to add, subtract anything?
No, nothing great can be done at this stage. He's got 2, and I'm worried what is the reason for pain? Is it the cartilage?
Is it CRPS? Sir?
So, nobody knows the answer, but my simple take-home message is that please do not follow literature blindly. Respect the glenohumeral joint is a small joint. Do not do too much surgery. Do not follow what somebody writes. Use your own experience, your own knowledge, filter it, and select literature judiciously. I did not do anything to the patient. I sent him back to the original surgeon and told him that you're the best surgeon in the world. I told the patient that go back to him and ask him to solve the problem.
Was it CRPS?
Sorry?
So, why do you feel the remplissage would be the cause for the pain?
It's just too much operation. If you think carefully, look at the evolution of instability management. Bankart repair used to swear by Bankart repair. And then suddenly Bankart repair went into disrepute. And we are giving too much importance to bone loss on the humeral and glenoid side both. What happened to the Hill-Sachs lesion in 1960s, 70s, 80s? They did very well. So think carefully, select your patient and surgery judiciously. If I had a glenoid bone loss, even with a moderate Hill-Sachs, I would just do a lethargia and come out. I wouldn't want to do too much surgery on a small joint like this. This is a classic example to prove that. Since we have another 8 minutes or so, 24-year-old female, 7 months post-arthroscopic Bankart repair. Nikhil, your take. She's 27.
First thought would be infection.
Yeah, maybe.
Yeah.
It's all destroyed. Now what do you do?
Go and take off all the hardware which is there, do a synovectomy, and put her on rehab.
Okay. Any of the panelists agree, disagree with that?
What is the current status? Pain?
Pain and stiffness.
Stiffness. It's infection.
So needs a biopsy.
I think I'm very concerned about infection here, so a biopsy will be an ideal thing to do first, and then treat appropriately.
And then eventually what would you do? Once the infection is under control, what would you, because she's bound to come back to you with pain. Now the infection is under control.
I'll send it to you. Honestly, I mean, this shoulder is going to be painful and stiff and arthritic in future. So
Yeah.
she's going to end up with some sort of arthroplasty in future.
Right, yes. So debride, clean up the joint, control infection, and counsel the patient that one day you may need some form of reconstructive surgery. So I think with this, I'm going to open this. Since we have another 6 or 7 minutes, anybody from the audience wants to say anything, want to discuss anything from this cases or any other case, you feel free, or else we'll wind up.
Sanjay sir, was it the cause of pain was CRPS in earlier patient? Complex regional pain syndrome?
Which one? The
One which had severe pain, which you did not,
lethargia plus remplissage.
you did not do anything for that patient. Could it be just CRPS and
I have no idea.
in clinic referral and maybe a block?
The surgeon had sent her to a pain clinic. They gave some injections and blocks and this and that, everything.
That does not
failed.
help.
Yeah. So I didn't touch that patient.
And second could be the chondrolysis. Severe chondrolysis is known after surgeries.
Yeah. But
That
in
could
this-
be the cause of severe pain.
Could be. But in this CT,
But CT cannot tell you. You have to have a MRI with cardiogram.
but there's a lot of metal around. There
But
are
the screws were removed. So that's what I was going to suggest. MRI with cardiogram, look for chondrolysis.
And then what?
So then you at least know the cause. He is heading for a replacement if you have a severe chondrolysis. And that could have solved or at least lead us to a diagnosis.
Thing is, Shantanu, he already scoped him, and there
Yeah,
was grade
he did.
2 on the glenoid.
Yeah, grade 2, grade 3, yeah.
I think arthroscopy is
But
better
point
than
well
MRI.
taken, point well taken. Mukhi Saab.
Excellent presentation, sir. I only think that, do you do a cervical MRI spine? One. And do you use antibiotic synthetic beads loaded in the last case to control your infection? Because you didn't do the culture.
The infected last case?
Yeah.
Yeah. So, sorry, what was the first question?
First question is, do you do an MRI to exclude cervical pathology?
Yeah. So when
Patient with severe pain may be having a cervical disc.
a patient has pain which is unexplained,
Yeah.
of course, I would not only do evaluation of the cervical spine, but I would also take an opinion of an abdominal doctor to make sure there is nothing subdiaphragmatic, and a thorough evaluation to look for alternative sources of pain. Even a gallbladder can give shoulder pain. So yes, we would. And in this case, there was no such reason. The pain was from the shoulder in that lethargy plus remplissage. Now coming to your second point about that infected Bankart in a young girl, we did an arthroscopic debridement, removed all hardware, took tissue culture as well as fluid culture, sent it for all the testing, put her on appropriate antibiotics. She settled down, but the shoulder is stiff. The infection and pain is under control, and we have counseled her that eventually when your symptoms are too much, you are too young for any arthroplasty-like procedure at this stage, pull on as long as you can, we'll consider them.
Because I have seen tuberculosis with the biopsy. So any culture, I do a biopsy.
Yes.
When the culture is negative, biopsy shows tuberculosis in some of the cases, especially in India.
So this lady's tissue was sent for both.
Both. Thank you.
Sir, excellent cases. I just wanted to ask regarding the trauma cases that you presented. So, for an average trauma surgeon, the message that I got is that there is a heavy sort of leverage or leaning towards doing a reverse or a replacement in the elderly. But we see so many fractures which are there, which are very well fixed. They also tend to do well. So, what is your message? I mean, would you consider plating in few of them, or would you have a very low threshold towards replacement?
No. So that's a good question, Ashish, and I'll summarize in a few lines. 80% of proximal humerus fractures do very well with conservative treatment. So keep that in mind. Remind yourself all the time that 80% ko to operate hi nahi karna hai. They do very well. Now the challenge is remaining 15-20%. In that 15-20%, if there is a 2-part, 3-part fracture, I don't plate, irrespective of age. I do percutaneous wiring, excellent result. It's about to be published soon. Superb result, no plating, 2-part, 3-part. I'm presuming that they need surgery. Now the challenge is 4-part. 4-part fractures and 4-part fracture dislocation. In that, I have a very clear protocol. Below 50, whichever, you must go for preserving the head of the patient, humeral head. No dispute. By a technique you are comfortable with for 4-part below 50. 4-part 70 and above, straight reverse. I do not want to do an operation which will necessitate a second operation at the age of 70. So for me, it is reverse. You have to know the technique of reverse. It is not an easy operation. Now, if you cone down to the real challenge is 4-part, 50 to 70, what do you do? I am convinced that the current methods of internal fixation are flawed. There is a failure of understanding. There is a failure of concept of the biomechanics which pass through the tuberosities and the head. In 50 to 70, I don't plate. I don't do hemi. I am in the process of innovating another implant. Currently, I use an intramedullary device called Just Unique, which some of you are familiar, but I am changing that. I am coming out with a new device, which is an intramedullary device, and the results are excellent. Those who want to read, it is published in Journal of Shoulder and Elbow Surgery 2020, and I'm going to speak about it today at 4:25, what to do between 50 and 70. I don't want to do reverse. Please do not go on doing reverse in younger patients. You will have problems. 70 and above, yes. 50 to 70, 4-part intramedullary fixation device, 425. Does that answer your question, Ashish? I hope.
So is it the...
One last question, because, or you can have 2 more, yeah.
Yeah, what's the problem in doing just unique in 50 to 70? In males especially, I am a bit wary of using it in females where osteoporosis is bad and you have collapse and failure of the tuberosities not joining in 4-part fractures. But in males with good tuberosities, with good bone stock, I think just unique is a very decent bailout option. And you're preparing for the future as well.
Just unique, the circular staple, which I will talk about in the evening, is the best way of controlling the head circumferentially. If you want to support a hemisphere, a screw or a central or side screw or any other device is not going to work. You need a circular support. That is point number 1. In my experience, male or female doesn't matter, osteoporosis doesn't matter. In fact, in osteoporosis, if anything is going to work, it is going to be just unique. Because screws are going to penetrate, head is going to fall into virus. We all have seen that. And they are like this all the time. So, irrespective of male or female, porotic or not porotic, I would still do intramedullary fixation device for 4-part 50 to 70. Mukhi Saab.
Expandable mesh bulb. You heard about this?
Yes, I am well aware.
Italian people, they are putting the bulb inside and then they are inflating it and it expands the whole head and you get the articular margin all right. So, what is your opinion on that?
Yeah. So, to me, it's an interesting device, but the philosophy is same. I think us here, sitting here, we have to first accept existing methods of fixation in 50 to 70 are bad. Something needs to be designed. We need to think and innovate. It could be anything like this or more to come in the near future. Thank you so much. Thank you, audience. Special thanks to all the panelists. Thank you very much. And thank you, WIROC. Thank you, Ashish.
For shoulder less is more. Yes, less is more.